Hello, everybody. Thank you all for being here. I know that there's been a lot that's been going on, and this will be recorded, so feel free to prioritize what's most important for you, whether that's learning here or your own self-care. But I'm here to prioritize cardiomyopathies at present, really focusing on how to diagnose and manage this well. So key things that I hope that we take away from this, really just making sure that we're understanding the pathophysiologic basis behind kind of four key cardiomyopathies. So thinking dilated, hypertrophic, restrictive, as well as ARVC or ARVD, and then also understanding some of the literature behind meth-associated cardiomyopathy, which we see a lot here. And then we can chat more about what makes the community heart failure program unique and who would be an ideal candidate for referral. Great. So, getting into cardiomyopathy, really, what is it? It's kind of a disease of the myocytes of the heart and something interfering with their organization that's resulting in subsequent disease. So when I got into this talk, I realized that I might have bitten off more than I could chew, looking at different classification systems. There is the AHA guidelines, looking at genetic, mixed, or acquired, and everything else kind of falling in there. And then there's also the ESC ones with hypertrophic cardiomyopathy, DCM, ARVC, and RCM, which we'll be focusing on. It's really just kind of a big headache. So I think our goal is really to focus on the key four, and everything else can kind of come in with time. If you all have any questions, please feel free to shout them out. I want this to be as interactive as possible as well. Great. Those are kind of the key things. So we can get into the first case. This is Arnold Schwarzenegger. He is an 18-year-old gentleman with a history of syncopal episodes with exercise. They last about 5 minutes without aura, with lightheadedness prior to loss of consciousness. Brought in by his friends to the ED at night with nausea, vomiting, persistent lightheadedness, and substernal chest pain. He doesn't take any meds at home. He's adopted, not in touch with his biological parents. In the ED, his vitals are notable for a pulse of 110, BP of 80 over 50, sitting well on ambient air. He doesn't look so great. He has some evidence of vomit on his shirt, scent of alcohol on his clothes. He has a holosystolic murmur at his mid-axillary area. Of course, an ECG is obtained, demonstrates some T-wave inversions and lateral leads, otherwise no ST changes, and has hypokalemia, hypochloremia, a creatinine of 1.5. You don't have a clear baseline because Arnold is not that well engaged in care. He's 18 and has a trope of 0.05. So ED focused, fast, negative, heart squeeze looks good, maybe too good. What would you do for his initial management? Any brave souls in the chat have thoughts? Dr. Tang says fluids. Anything else? Yeah, absolutely. And I think fluids and potassium are certainly kind of the first things that I think about. One of the things that I would also be considering is whether or not this patient could benefit from beta blockade as well. So this gentleman sounds like he has signs and symptoms that could be consistent with hypertrophic cardiomyopathy. And certainly there can be some evidence of pathologic disease, which we'll get into as to why we end up using beta blockade. But certainly fluids are the kind of first thing that I think about as well. Great. So hypertrophic cardiomyopathy, we'll talk about it a little bit more. The pathophysiology is really just mutations that are in the myosin heavy chain, myosin binding protein, also in changes in some of the sarcomeres as well. So ultimately, what you end up seeing is you have a pretty stiff ventricle. Sometimes you can have outflow obstruction, as hopefully you can see my cursor here. You can see that there's some degree of narrowing of this ability for the blood to exit the ventricle as well. You can also have mitral regurgitation because you can have systolic motion of the mitral valve in the setting of this kind of narrowed outflow tract. So as a result, that's kind of what we typically can see. And that's also why we think about fluids for these patients, because what we're trying to do is basically open up the ventricle when people are maybe volume depleted. When we were chatting about Arnold, he might have been some degree of fluid down in the setting of his alcohol use as well as his nausea and vomiting, leading his intraventricular cavity to actually sometimes end up collapsing in on itself. So people can have really significant issues with syncopal episodes and basically hyperperfusive kind of events. As far as the epidemiology of this, it's relatively common actually. 1 to 200 to 1 of every 500 patients can have this. Notably, it has autosomal dominant inheritance as well. There's some degree of racial and ethnic disparities. And then as far as, further things that we think about, we typically use like TTEs, cardiac MRI. We're really looking for any sort of thickening of the ventricle itself to be greater than 15 millimeters, without alternative evidence of hypertrophy, thinking about like hypertension, other things like that. If we knew Arnold's family history and he had a like family member that recently had a sudden cardiac arrest or other things like that, we might use a kind of slightly lower cutoff. There's some stuff around children. I don't treat children, but typically thinking about like kind of body surface area and other things like that. And then as far as wall distribution, it can really happen anywhere. As far as late gadolinium enhancement, this is something that's actually pretty important as well. It can be a reflection of kind of inflammation that we end up seeing in the heart, and it's often seen in cardiac MRI. And it actually functions as a risk marker for adverse complications like sudden cardiac death in patients with hypertrophic cardiomyopathy or rapidly progressive disease. So as far as the general natural history and course, 30 to 40% of patients with genetic changes develop adverse events. It does have some degree of variable penetrance, but thinking about the clinical outcomes there, the risk is really not worth the benefit for missing something like this, sudden cardiac death, heart failure, and other things like that. AFib is also one of those concerns as well in this population that's worth noting. But if we're able to treat people, the mortality rate per year decreases from like about 3, I think, to 6% to less than 1% annually. And it's usually quite useful. So as far as management, we can get into it a little bit. As far as sudden cardiac death or VT, think about an ICD for patients. And there's a great tool for risk assessment. This comes from the European Society of Cardiology for risk assessment. You basically just kind of plug in all the data there, and it'll help you kind of figure out whether or not this patient would benefit from it. Also, if you have somebody with hypertrophic cardiomyopathy, you can refer them to cardiology. As far as the outflow obstruction, things that are useful, thinking about negative inotropes, beta blockers and verapamil are usually our first line. Disopyramide is a second option, but often can result in kind of more profound EF depression and other things like that. Interestingly enough, cardiac myosin modulators have been more and more exciting and kind of on the rise. Mavacamten is something that basically goes directly into the myosin kind of binding complex and subsequently kind of is able to decrease contractility in a positive way. We saw this in the Valor HCM's trial where patients who were thought about receiving like any sort of surgical or procedural intervention ended up not necessarily needing that when they were starting on mavacamten. And then also in the Explorer HCM trial, these all were in the last few years, and we saw that people have symptomatically been doing much better with this. And then other medications you typically want to avoid, anything like vasodilators, nitro, anything that's causing pooling prior to the left ventricle is actually not going to be useful for you all as well. And then other things that would basically cause the heart to squeeze harder than we would hope. So dobutamine, dopamine, stimulants for ADHD also can exacerbate some of these symptoms that people have. And then non-pharmacologic agents, making sure that people drink water and then avoid alcohol and caffeine given some of their diuretic effects. And then as far as procedures, so myectomy is basically going in and cutting out some of the intraventricular septum. It sometimes actually leads to significant changes. in people's mortality. You can see this blue line is all-cause mortality for people who had an isolated myectomy as compared to patients who had basically medical management. And we see that many more people survive. And then alcohol ablation, this is something that's also done. It didn't really seem like, the way in which I would offer this to patients is thinking about whether or not they're really interested in pursuing surgery. It can be very helpful in treating people, but it does have some degree of variability of effect, whereas myectomy is a little bit more of a definitive treatment. And then last but not least, a lot of patients end up developing atrial fibrillation, so trialing antiarrhythmic drugs. If they're getting a myectomy already, they can go in and have a maze procedure, so an ablation done during surgery. And then thinking about anticoagulation is always a risk-benefit discussion. I talked about a lot here. If there's any questions, feel free to toss them in the chat. And then I think one of the things to think about is what about non-obstructive hypertrophic cardiomyopathy as well? So the key thing is just seeing whether or not this is actually HOCM or obstructive cardiomyopathy that's just hiding without exercise. And then usually what we think about for these patients is transplant evaluation or kind of CRT to help synchronize the heart as well. So those are kind of my thoughts. And I have a nice little picture for you. If I talked a lot, these are kind of the key pearls that I hope that you take away. So thinking about an ICD for patients who are at high risk of sudden death, when people have obstructive disease, thinking about a myectomy or an alcohol septal ablation or the ASA, it's not aspirin. And then for progressive heart failure, also thinking about heart transplant or trying to medically optimize. And for atrial fibrillation, there's some of those treatment algorithms there. Great. So with that said, we'll move on to our next topic. So this is another case. I don't have a fun name, but this is an 18-year-old woman here with VT. She had a baseline ECG completed 2 months prior. There is a small abnormality. This is the baseline EKG that we're looking at in the precordial leads. Is anybody familiar with what this abnormality might be that the blue arrows are pointing out and what it suggests? Yeah. Stephen and Christine, both of you are perfectly correct. So this is actually a epsilon wave. Um, it's a little ditzel that's basically kind of buried within the QRS complex. One of the challenges is discerning this from an Osborne wave in patients that have had severe hypothermia, other things like that. You can usually use the clinical history to correlate a little bit more. I'm sure that there are some EP related criteria as well. J waves or Osborne waves are typically a little bit larger in size, whereas epsilon waves, as we're seeing here, they're not all that big. So yes, this is a condition that, well, an ECG finding that is associated with arrhythmic RV cardiomyopathy or dysplasia. This is a relatively rare condition. 1 in every 5,000 people have it. Autosomal dominant inheritance, incomplete penetrance, so not everybody will develop disease, but it's commonly passed along. And what happens in this condition is that patients have progressive replacement of myocytes in their heart with fatty tissue. It's not really certain why this happens, but it's not necessarily thought to be an inflammatory process. There's some association with myocarditis, though. Clinically, people are usually well until they're not. So they can develop VT, typically monomorphic, and then they can also develop sudden cardiac death. Workup for this would really just include ECGs, Holter monitors, echocardiograms, or cardiac MRI. Typically, we can see basically structural changes in the RV, and then referral to electrophysiology if you see these changes, or at least to a cardiologist to make sure that we can further assess this patient's risk, and then think about whether or not they benefit from an ablation. And then I think the most useful thing that we as internal medicine doctors can do is also making sure that we're getting a family history and getting, not just immediate family, but also thinking about grandparents and other things like that. It can be actually very useful to help us better understand. Great. So next up, we'll chat about kind of dilated cardiomyopathies. So it's dilated cardiomyopathies are kind of a catch-all of a phrase. It's really just any sort of process by which you end up having kind of eccentric dilation of the heart. And there are many conditions that can lead to this. As far as the epi of this, typically, um, one of every like 2,500 patients can have this, but I think that number actually might be a little bit higher. 40% of them do have non-ischemic cardiomyopathy. Many people can have onset in their 20s to 30s, depending on the etiology. But if some people have like ischemic disease, which is sometimes thought to be grouped together and grouped separately, that can typically happen a little bit later on in life too. Um, as far as other classification, this can be mixed. So there's some genetic and non-genetic contributors. There's a pretty broad differential of causes that can kind of drive this. You can have infectious causes such as kind of viral myocarditis. You can have toxin mediated, which I'll talk about at length in a little bit. People receiving chemotherapeutics can also see this as well. Any sort of ingestion of metals, and then there's a good amount of familial cases that can mediate this as well. When we think about familial cases of dilated cardiomyopathy, things that can be useful for boards is that Lamin cardiomyopathy is the most common one. Titin is a close second. Great. As far as workup, there's a lot here. The right side of the slide is really just for your reference in the future. Really just thinking about getting a detailed family history, ECGs for most people, looking for AV block, and then also thinking about ferritin and transferrin. For toxin mediated, really just kind of exploring history, getting your urine drug screen if you're very concerned. And then, there are certainly some infectious causes that can mediate this, thinking about travel history. I think that getting an HIV test for everybody in general is great, and this is just another reason why we should. And then also metabolic, thinking about thyroid dysfunction and hyperthyroidism is mediating some of this. And then, people always think about PHEO, other things like that. I would probably hold off unless you have a really convincing story. And then for inflammatory disease or other things like that, you can typically look for an ESR, CRP. And other than that, sometimes, tachyarrhythmias are oftentimes invoked as kind of being a driving cause. It really does take a good amount of time for that, and people do need to have a pretty elevated heart rate. So I try to think about it as a diagnosis of exclusion unless they do have persistent elevated heart rates for quite a long time. And then let's see, as mentioned, for inflammatory etiologies, you can also get sarcoid evaluation with chest X-ray, ECG, serum ACE as well. I typically don't see very many kind of neuromuscular diseases, so I would probably just get a CK to screen and then refer for further workup if you're very worried about that or if there's a family history. Great. So the key thing, I'll highlight here is just like clinical presentation and outcomes really do vary by the specific subtype. I'd love to get into it more, but I feel like DCM and its exploration could really take an entire 45 minutes as well. I think the last thing that I'll impart in this regard is that calling it non-ischemic cardiomyopathy is not enough. In our one-liners, sometimes it can be useful to say, oh, this person has HFrEF, EF is like 24%. Non-ischemic, but if we're able to dig a little bit deeper and find out why this person presents in this way, is it thyroid mediated? Is it some degree of iron kind of derangement or something else of the sort? That helps us kind of think about what we can do for therapies and subsequent prognosis too. So when we think about treatment, it is once again cause dependent. I wish that I could get into this a little bit more, but our GDMT is great, and getting patients on all four pillars is actually quite useful as well. There's a bunch of studies thinking about the strong heart failure study and other things that have found that when we get people on all four pillars of GDMT at their kind of initial hospitalization, their risk of subsequent rehospitalization is much lower. I will say that that's challenging, thinking about finances, especially at places like Harborview and other things like that, and challenges to follow up. So also just making sure that we can subsequently make sure that people have close follow up as well. If there's any sort of valvular disease, we try to treat that. If there's any sort of history of a pacemaker in place and pacemaker-mediated cardiomyopathy, especially if it's just a single lead in the right ventricle, you could consider cardiac resynchronization therapy. And then also other indications for CRT or is if people have persistently low EFs despite 90 days of optimal GDMT, along with kind of a widened QRS as well. And then, advanced, we probably won't see that all that much as internal medicine doctors, but thinking about mechanical circulatory support and subsequently transplant as well. Any questions here? Great. So this is Bill Murmury. He's 48, has a history of hypertension, hyperlipidemia, treated hypothyroidism. He is unfortunately experiencing homelessness, has a history of inhalational methamphetamine use, an EF of 24%, had a prior ischemic evaluation that was negative, presumed to be secondary to methamphetamines, presenting to the ED with shortness of breath, lightheadedness, dizziness, early satiety. And he's had multiple challenges making cardiology follow-up with his ED presentations. He takes Coreg 25 BID. For some reason, the rest of the medications didn't populate here. He's also prescribed Entresto, 4951. You name it, he's just getting everything. He's got Spiro and empagliflozin all prescribed. Does he take them? It's not super clear. As far as his ED course, he has a little bit fast of a heart rate. It looks like he has volume overload, has a BNP of 700, has a UDS with methamphetamines, and some degree of pulmonary edema. Our friends down in the ED were just ginger around his diuresis initially, and they gave him PO Lasix. I think one of the pearls is that when we think about, diuresing people, we should just give them IV. They can handle it usually unless their blood pressures are really kind of on the fritz. And we typically give IV for multiple reasons. The prior paradigm said that, it's gut edema that is impairing uptake. Well, that might drive some of it as well. There's a really great Curious Clinicians podcast about how it's possibly mediated by some degree of altered peristalsis among patients who have kind of volume overload and changes to their gut as well. So this patient is ultimately admitted to, let's say, the Harborview CCU and cardiology service and diuresed to eubulimia. And my question for you all is like, how are patients with meth-associated cardiomyopathy different from other patients? And how can they be treated differently? This is a little bit of a rhetorical question. I can wait a little bit unless people have thoughts, and I can get into it. Wonderful. So let's chat about meth-associated cardiomyopathy. This is a near and dear issue to my heart, no pun intended. This is a condition that is increasing in prevalence with changes in meth use. At least in Southern California, it was 5.6% of all cardiomyopathy cases in 2014. And I presume that number has continued to balloon based on substance use trends here on the West Coast of the United States. Typically, younger patients, some of them might have some genetic predisposition. Key things that we look for diagnosis. Typically, we'll think about left ventricular dilatation. You can also see RV changes. Don't forget that meth use is also associated with pulmonary arterial hypertension or a group 1 pulmonary hypertension. So sometimes you can also see Takotsubo as well. Prior treatment paradigms had said that, meth cessation is the key recommendation, and GDMT didn't demonstrate as much of a response. I see your question, Danica, and I'll get to it in just a second. And I think the way in which this is actually mediated was thought to be secondary to meth directly causing sympathetic activation. Your heart ends up working a good amount more. You have some degree of ischemia, and then you could develop acute and chronic cardiomyopathy as well. Meth, when inhaled or injected, is directly cell toxic as well. So you can see kind of a two-hit mechanism that can lead to meth-associated changes. So this is actually a great question, Danica. Thank you for asking it. I think there is some degree of a dose-related kind of response, but there are certainly some people who have had a prolonged history of methamphetamine use who don't end up developing kind of cardiomyopathy. And there are some people that also have a history of maybe using it for a short period of time and they can have really bad disease. And I think one of the things that I want to highlight is Cooper Kersey, one of our prior residents who is now a fellow, just recently published a paper around ischemic evaluation in patients with meth-associated cardiomyopathy. Once we have, unfortunately, once people have any sort of likely cause for the people's heart failure, it's a lot of the workup ends up going out the window. So in patients who have a history of meth use, a lot of them end up not getting any sort of ischemic workup with like a coronary calcium score, or sorry, any sort of coronary CT, or any sort of kind of diagnostic angiogram as well. So I think that there's more that needs to be done in this regard. Let me know if I didn't answer your question appropriately, and I can chat about it more. Yeah. Great. So what can we do? So the Community Heart Failure Program, or CHFP, is one of the things that I think is the most useful. It's a referral that's indicated for patients with significant challenges accessing care. Our mobile team meets patients where they're at. This is, pulled from Fox News as well. And they're able to provide labs, clinical assessment, medications. I think I remember that they might have an ultrasound that's portable as well, or it's just a pretty robust service, and we're able to complete most of the outpatient care that people need just on the street or at their homes, other things like that. I published a case with our case series with this team, seeing that when we got people engaged in this service and also gave them an alarmed metaset, so one that was typically used for dementia patients, it's locked. It ends up kind of rotating after alarming through like a 28-day cycle. And, you're only able to give meds once a day. But we saw that people's adherence went to like 100% from like maybe in like the 30s or so. We saw decreased use of methamphetamines, improvement in people's EF from like, 12 to 20 to like 40s to 50s. And their NYHA functional class went from like, NYHA 3 to like NYHA 1 or 2. And we also saw that patients had decreased incidence of overdose when we were able to just provide them with like other things like naltrexone and other things like that. So pretty exciting. If you're interested in referring people over to the Community Health Heart Failure Program, you can reach out to Jamie Peachin or Kate Smith. Also, you can reach out to Mernal Yadava as well. They're all great people, and I think would certainly be happy to respond to any sort of epic and basket messages. Great. Not last, but certainly not least, this is Shane the Rock Johansson. This is a 68-year-old gentleman with hypertension, hyperlipidemia. He's been lost to follow-up for 1 to 2 years. Has some degree of progressive dyspnea on exertion, shortness of breath, lightheadedness, orthopnea. Also has some dizziness and has had some hand numbness and pain over the past year. He didn't really like his prior PCP. He was over at Virginia Mason. You know that they don't play all that nice with Epic charts. So they were recommending a bone marrow biopsy. He's like, why? I don't really get it. We weren't able to get any labs for him. Unfortunately, a shame. He looks fine, actually, as far as his vitals. Um, he did have some numbness or tingling. His Phelan's was positive. Tinel's was negative. Maybe you didn't use a reflex hammer or something of the sort. Raising his hands above his head for about 2 minutes reproduced hand symptoms between his thumb and middle finger. As far as his cardiovascular exam, his JVP was a little bit elevated, has a holosystolic murmur at his right upper sternal border. Um, Labs, we don't have any for the sake of this question. And what would be your next diagnostic step for this gentleman? What would you want to get? Yeah, no, I love it. Thank you for that point, Angela. It's certainly kind of challenging, I think, the community heart failure program, just to step back for a second, is trying to think about how we can make the most impact as well. And if patients are kind of seeing cardiology every so often, it makes it harder for us to kind of consolidate their care in one place, either in like a brick and mortar outpatient setting versus a mobile outpatient setting as well. I'm seeing some SPEP, UPEP, cardiac MRI, excellent thoughts. And yes, after a TTE, of course, we're providing value-based care here. And then one stretch question for you all is, what known or approved therapies exist for some of these conditions? And this is something that you can think about over time. And I'll go to kind of the next step. In this patient that is having maybe some degree of carpal tunnel with additional cardiac findings that are concerning for heart failure, I'd be really worried about something like cardiac amyloidosis. There's a lot on this slide. I think, just walking you through it in a way that is a little bit more kind of streamlined. Yes, sarcoid is certainly on the differential, which is why I think cardiac MRI is appropriate as well. Typically, the first thing I'd look for is just seeing whether or not there's any sort of changes in light chains. And, if there is any sort of alteration, then what seems most likely is an AL amyloid process. So getting in touch with heme, thinking about biopsies, other things like that. So, Ananya, I think you mentioned endocardial biopsy. That can actually be something that's useful, but actually, I think tissue where they can get it is actually appropriate initially for AL amyloid or anything else like that. Okay. Yeah, but if you're able to find it like in the abdominal fat pad or somewhere else like that, then you might be able to make a diagnosis without needing to kind of go in with a much more invasive procedure, as much as I think endocardial biopsies are quite cool. And then, there's also other etiologies. So when we think about amyloid, there's AL amyloid, so light chain, and then TTR, transthyretin amyloid. So TTR amyloid is when this protein, transthyretin, does not fold appropriately and ends up kind of depositing in different places. So what we see here in this workflow slash algorithm is that if there is the option for a PYP scan, this is actually quite useful in assessing for the possibility of ATTR amyloidosis. So if that in and of itself is positive and available, then you can actually clinch a diagnosis of ATTR cardiomyopathy. If not, you can also do an endomyocardial biopsy and then do some staining on it and then kind of get to the same area and conclusion as well. So that gets into restrictive cardiomyopathy. Oh, wonderful. Oh yeah, I think that just came out recently, right? Thanks, Tony. So as far as the definition, it's similar in a way to hypertrophic cardiomyopathy in that you end up having kind of a stiffening of your left ventricle, but this seems a little bit more pronounced in both the left and right ventricle. You have alterations in your systolic volumes and normal wall thickness. The one way I would think about this a little bit differently from hypertrophic cardiomyopathy is that you have alterations to the Frank-Starling curve a little bit more in restrictive cardiomyopathy. Whereas with hypertrophic cardiomyopathy, you still have kind of normal well, you might have some degree of inflammatory milieu, but you might not have as much kind of deposition of protein or anything else into the myocardial area that makes it stiff. So I think of restrictive cardiomyopathy as your heart becoming generally more stiff like a wood board and not really responding all that well to any sort of fluid response and having the kind of smooth Frank-Starling curve that we are used to. There's a bunch of causes that can mediate this, but I'd really just think about our big three: amyloid, sarcoidosis, as well as hemochromatosis. So I'll kind of go through them in sequential order as well as far as their epi. Amyloid's pretty rare for AL. ATTR, we aren't super certain of the prevalence of this. Sarcoidosis is actually quite common. Well, relatively. So like 50 to 60 cases per 100K in Scandinavia, which is kind of the area of highest incidence, as well as Japan. As far as the US, there's race-based differences here and in the rest of our care as well. There's 11 per 100K in white populations, 35 per 100,000 in black populations, and it's more common in women. I will say that cardiac amyloidosis is more rare of an outcome. 2.5% of cases present with this. Hemochromatosis is, the third cause. It's actually pretty common as well. AR inheritance, incomplete disease penetrance as well. Yeah. Oh, thank you, Ananya. This is great. Um, so that kind of leads us to pathophysiology and clinical presentation. As we mentioned, there's some degree of kind of inflammatory picture that can sometimes mediate this with sarcoid. But as far as amyloid, we mentioned how you can have either AL protein or like TTR ending up in the myocardium itself. And then hemochromatosis is mediated typically by this kind of mutation in HFE genes, and you end up having deposition of iron. As mentioned, you can see this kind of stiff ventricle, usually without left ventricular outflow tract obstruction. And yeah, I think, it's a little bit hard to see these conditions until it's a more late stage as well. I think one of the things that can be useful and that I might not have mentioned too much is actually completing an echocardiogram and seeing strain kind of patterns on it. So strain is a measure of how well our heart is able to kind of respond. And in patients who have restrictive cardiomyopathy, you can see specific strain patterns that are actually more indicative of, oh, hey, this might be consistent with sarcoid, or hey, this might be more consistent with an amyloid-based process as well. But as far as diagnostics for amyloidosis, you all nailed it, an SPEP and UPEP, and then getting a PYP scan, thinking about an endomyocardial biopsy as you need it. Cardiac sarcoidosis, certainly challenging. ECG, chest X-ray, as mentioned, the strain changes, and then, thinking about cardiac MRI as well. So some of these patients can actually have evidence of what we call late gadolinium enhancement, which is sometimes a little bit more patchy in cardiac sarcoidosis compared to other diseases. So, we can also think about PET CTs for some of these patients, but, I had a patient who had to complete this in the hospital and they're like, I can't have any sugar for like 24 hours or something else like that. It was really kind of tough for them to go through that. And then last but not least, a voltage gated endomyocardial biopsy. So voltage gating basically means that when they go through the biopsy, it's not necessarily fluoro guided, but they actually look to see whether or not there's areas that are more consistent with scar, and they can actually take samples from there, and that does increase the yield by a good amount. I think from like the 30% to something a little bit higher. And then, hemochromatosis, you'll see some degree of iron overload on basic labs. And as far as treatment, there's some changes here and there that are continuing to be exciting. As far as AL amyloidosis, usually it's just treatment of the underlying cause. You can do kind of some proteasome inhibitor treatment with stem cell transplant and chemotherapy using daratumumab. And then, one of the real challenges is late stage. There aren't any FDA-approved treatment options that are going to be quite useful. I think people have been mentioning that there's some scavenging antibiotics or antibodies that are hopefully going to kind of go into the cardiac regions and help withdraw them, but I think that's been difficult to bear out in practice. ATTR amyloidosis. So this is pretty exciting in that we have the development of tafamidis. Previously, this was kind of a condition that was thought to be very, very rapidly progressive. Tafamidis is an agent that helps stabilize the tetramer of transthyretin when it's generated, so it ends up not breaking up into its kind of monomers where it's able to deposit into the heart. Additionally, kind of a throwback to OG bio days, you can use small interfering RNAs to kind of decrease TTR synthesis. I don't see that these are used all that often, but patisiran and vutrisiran are agents in this class as well. Cardiac sarcoid, certainly one of those conditions that can be managed with heart failure medications, antiarrhythmics, immunosuppression as well. So steroids are kind of one of our first line agents, but also steroid sparing if we need to have them. kind of for longer periods. And then, if patients have high grade AV block, then device therapy is one of those things that we think about. And then orthotopic heart transplant, we actually have a good volume of that here at the UW, at UW in general. So that's one of those things that our heart failure team manages. And then last but not least is cardiac hemochromatosis, which is managed by therapeutic phlebotomy, and people typically improve a good amount thereafter. Those are kind of the key things that I have. I talked a lot, so I'm happy to entertain any questions, and I really appreciate you all being here. Here are my references, and I think that's it. What questions can I help answer?
Maybe Joey can stay on for anybody who has questions for him. And we've got, looks like somebody rose their hand. But if you do not have questions or you don't want to stick around for questions, feel free to peel off.
Great.
Look like Jenny maybe has a question. Go ahead.
Oh, Jenny, I see that you might have a question. Oh, great. All right. Thanks, y'all. Of course, I'm going to keep it a little bit engaging.
Thank you, Joey. And I think Alyssa maybe has popped off already, but that was an amazing talk. Really appreciate you guys doing
Oh,
this.
Tina, I can't hear you for some reason.
Can you hear me now?